Hi, today we'll be talking about increasing family satisfaction in the NICU, specifically looking at communication standards. My name is Jennifer McTague. I'm a student at Southwest Baptist University. This slideshow fulfills a requirement for research and evidence-based practice curriculum. Let me introduce you to my topic, family satisfaction. Why is this topic important to me? According to the Centers for Disease Control, 1 in every 10 births in the United States in 2016 was a preterm birth. The earlier a baby is born, the greater the chance he will require an admission to a neonatal intensive care unit. He may need to be hospitalized for an extended amount of time. Therefore, family satisfaction is paramount in the neonatal ICU because the focus of care does not solely reside on the neonate. Care models should focus on those who are considered the primary caregivers as well. Satisfying the needs, reducing stress, and calming the fears of caregivers or family members means making the experience therapeutic as well as enriching. Additionally, including caregivers or family as members of the care team increased trust is elicited and adherence to treatment plans is seen. As pointed out by one of the research articles I studied by Gojobobachev and al. My experience as a bedside nurse in a local NICU has granted me expertise in caring for neonates and their families. And I have found that a key satisfier is enhanced communication. Communication which involves providing day-to-day, up-to-date information about the patient from all members of the medical team. This is crucial in satisfying the needs of families in the NICU. So why is this important to the public? Well, a lengthy stay in the NICU is extremely costly. It is estimated that one day or one bed space in a local NICU is about $3,000 a day. This does not account for the expense of equipment, caregivers, and other multidisciplinary needs that would be given to a neonate. Additionally, this most vulnerable patient population requires multifaceted care. This multifaceted care should emphasize family-centeredness, as we know that families who adhere to treatment plans and who involve themselves in the care of their babies are successful in feeling confident to care for their little one at discharge and beyond. Continuing with the importance of family education is why is this important to healthcare systems? Well, specifically to the level 3 NICU that I work for is a marked reputation to uphold. In that respect, we will often say things like, we represent the best NICU in the region, or your baby will receive the best care in the region. While it is true that all NICU, level 3 NICUs most likely offer the same standard of care, we hope to aim to make the experience as significant and unique as possible. And in doing so, we honor what the bond between family and neonate means Increased awareness and adherence to treatment plans is essential because the ultimate caregiver is the family or the mother or father or guardian, and they will be empowered to facilitate the care needs of the neonate infant on into early childhood. A lot of the infants are impacted by premature birth, both neurologically and physically, creating demands on the family which must be met in order to give best quality of life. So why is this important to patients or the subjects of this review? Because validating family concerns reduces anxiety and increases satisfaction. Also, the family system is at high risk of psychosocial stresses, and the family system should attain a degree of integrity that allows family members to assume the role of primary caregivers for the infant, which I have previously highlighted. Speaking to caregiver role and what that means down the road for a family of an NICU patient. Meffert and Ali Good tested Levine's conservation model of nursing in a level 3 NICU. Their study involved observations made with 235 preterm infants. Their findings concluded that a model of consistent care nursing was a significant marker of health and that both the infant and family attain a level of independent functioning that enables the infant to be discharged at or before the expected due date for a term pregnancy. This is part due to the consistency delivery of nursing care, which supports family patterns and individualizes nursing interventions for a specific infant and his family. This is achieved through mindful communication. So my PCOT question was, for patients in the neonatal intensive care unit, does a standard communication model compared to no standardized communication model impact family satisfaction for those who have admission stays of 7 days or greater? I argue that creating a communication model or developing a communication strategy with caregivers or family members increases satisfaction. My search results were directly from the Sentinel Complete database accessed using the Southwest Baptist University website at www.sbuniv.edu. I clicked on the database tab. The search terms I entered were family satisfaction and neonatal intensive care and communication. This yielded 303 results. I then narrowed these results by filtering this search using full text and publication date of 2008 to 2018, as I wanted the most up-to-date information. This yielded 109 results. A review of the article's abstracts helped me to narrow these results as I searched for keywords such as communication, family satisfaction, neonatal development. After reviewing several abstracts, 5 articles were retained based upon relevance of the PCOT question. These articles were reviewed. The rationale for selection of these articles are as follows. They are level 2 research-based studies. The studies obtain consent from the participants. The study aimed to validate my PCOT question. There were expert review or expert involvement was paramount in these research studies, meaning it was guided by experienced nursing staff, physicians, nurse practitioners, and qualified by review boards representing the institutions which employed the study or survey. Furthering the rationale for using the following articles was what they measured. All 5 articles used studies that were quantitative and qualitative in nature. Quantitative in that there was numeric representation of observations using statistical techniques for the purpose of answering the study's hypothesis, and qualitative in that there was words or phrases used to explain the outcomes of the studies, making it more human-friendly. The summary of my findings. Similarities. 3 of the 5 articles/studies used a form of the Likert scale to collect data. Likert scales ask questions which ask the reader to state whether they strongly agree, somewhat agree, strongly disagree, or somewhat disagree with the content of the question. All 5 articles were performed at a level 3 NICU. The rule of 30 or sample size factors, which asserts that in a randomly generated sample, 30 or more subjects, the mean of a characteristic will approximate the population mean. This applied to 2 out of the 5 studies I reviewed to include a survey of physician parents of NICU patients and a large sample from the NICU from a level 3 NICU studied by Mefford and Alligood. However, one of the studies' design was only on focus groups, while the other one fell short of the rule of 30 by 2. All 5 studies received Institutional Review Board approvals to perform their research. All 5 studies identified that some degree of communication strategy is paramount in involving the parental or family unit in the care of their neonate. Summary of findings, limitations. One study used focus groups of 8 total parents. This is not a good representation of a level 3 NICU. This same study was collected from white, employed, English-speaking parents, in which I would add that providing a more diverse culture sample would have made the study more valid. Wise and all pointed to the language difference between families and PMPs, or primary medical providers, was associated with decreased satisfaction with communication before the intervention, whereas maternal ethnicity was not. Satisfaction among non-English speaking families increased after the intervention, thus highlighting the importance of interpreter services. This is to say that anyone with limited understanding of what is being communicated should have or be offered interpretive services. Mefford and Alligood's research was applied to those who were 37 weeks or less in gestational age during the time the survey was taken. This excludes term gestational families who may have only had an admission stay of a few days. Thatton and al. Identified the large gap in their research as participant recruitment. There are no local or national databases of either NICU patients with public access to parent occupation or physician parents. Participants were recruited because they were known to one of the study investigators. Thus, a selection bias may have occurred because investigators may have been more likely to recall physician parents they believe had a favorable experience, or physician parents with a poor experience may have transferred care to another institution. Therefore, the views expressed by surveyed respondents may not represent those of all physician parents of NICU patients. Conclusion. There were 19 comments on the content of parental communication from one survey, recommending a set time of day to meet with neonatologists and that the discussion present both positive and negative feedback aspects of the patient's current status. This same survey asked Likert formed questions about communication in the NICU. 47 physician parents responded. 6, which accounted for 13%, comments were not specific. 9, which accounted for 19%, were satisfied with NICU communication. 32, which accounted for 68%, made suggestions for improvement. And 15, which estimated 47% of these suggested more communication with parents to increase satisfaction. Parental family satisfaction is conclusively improved when a thread of communication is established with the families and the primary medical providers. Contributing to this finding is posting signage which identifies the care team of an NICU and a tool for how to contact the NICU. Parents/families of NICU patients need a direct communication with the medical provider on a daily basis in order to feel up to date on the status of their baby and to feel satisfied. Consideration of family concerns and preferences in daily care planning and improve family-centered communication, thereby decreasing parental anxiety and increasing satisfaction with NICU care. However, making it a point to address the needs of families during medical rounds may not be the most appropriate time to do so, as medical dialogue is difficult to understand and may distract the family. Finally, nurses highly attuned to an infant's unique modes of communication and who know the family should be better able to design and implement holistic nursing care interventions supporting adapted efforts of the infant and family and therefore restoring health. Thank you.